We're back with Dr. Ken Sands. He's our Chief Epidemiologist, Chief of Infectious Disease, and Chief Patient Safety Officer. Three hats that have been keeping him very busy at HCA Healthcare for the last couple of months, and greatly appreciate the many grand rounds that you offered. We've received a number of questions in through the system, and I want to also thank Sandra Morgan and the physician and provider relations teams for bringing these questions to us, and try to organize some of them as they've come in into infection prevention and safe practices, diagnostics, and some complications of the clinical course. So we'll start off with one that's somewhat policy-oriented, which is what is our HCA posture on elective procedures, both in terms of the social responsibility for infection prevention and preserving personal protective equipment and potential surge of COVID patients itself. Well, I'll take this one, is that policy is being set not only in HCA, but really globally. CMS, the Medicare program, has put forward guidance that says those things that are truly discretionary should be curtailed. Those things that may happen to be scheduled, but are not really discretionary, debulking surgeries for a cancer patient, a patient with multivessel coronary artery disease, need to proceed. But really, this means that you as clinicians have to make a bit of a judgment call, as there is no bright line between that which is truly discretionary and that which happens to be scheduled. And obviously, situations may change over time. You may be in a community where there's limited activity of COVID and resources are robust for those sets of activities. But should you be in a community where a surge is occurring, the protection of personal protective equipment, the infection prevention really takes first order. And we thank you very, very much for that. Okay, Ken, I think this next one goes to you. And this is a question about doffing personal protective equipment when you're coming out of a room that doesn't have an empty room. What's the best way, most hygienic way, safest way to get rid of that PPE in that situation?
You know, it really is the ideal to do the doffing once you've exited the room, if there isn't any room, or if there is room in the hallway for that trash to be disposed of, and doff outside the room. If that's not possible, it's back to the science, and the recommendations are that if you are more than 6 feet away from the patient, you're likely protected, aside from in the occurrence of an aerosolizing procedure. And so if that doffing can occur with at least 6 feet of space from the patient, you're protected.
Okay, so you mentioned a couple of things, and I want to dive into them a little bit. Mm-hmm. When is it okay to continue using the same personal protective equipment? As everyone knows, there's a international shortage of certain equipment like masks, mm-hmm. N95 respirators in particular. Talk about that for a minute.
So we've issued some guidance on reuse of equipment, and the CDC has been very specific even before the outbreak of COVID that under certain circumstances, such as a shortage or an outbreak, it can be appropriate to reuse N95 masks. That has been the focus of some of that reuse. And so we have adopted that guidance, and we've provided through our vehicles of dissemination of information, including the Atlas website, the instructions for how a healthcare worker can be issued one N95 for a shift and reuse that N95 through the course of a shift appropriately and safety. We are also looking at reuse of other items such as face shields and the appropriate processing mechanisms that would allow for those to be reused. And there may actually be ways to actually reprocess N95 masks so that we can buttress our supply of N95s in a way, again, that is safe for our staff.
That's great. And so guidance will be forthcoming on the potential for reprocessing of these masks, but it means that at a certain point there may be specifically labeled receptacles, bags with a different color that are used to collect those N95 masks so that they can be appropriately reprocessed and sanitized. Mm-hmm. Now, you talked about the reuse of face shields, and some people have noted or asked the question here about the appropriate use of goggles. Is that an adequate substitute?
Yes, it's goggles or face shields. Either of those is an appropriate form of eye protection. Some people prefer goggles for wearing for long periods of time, and so those is certainly acceptable protection.
Okay, now this gets into a little bit of a tricky area. As clinicians in the care environment, we may get ill because we meet people in the community. We may get ill by something that looks like coronavirus. We may get ill actually with COVID. If a healthcare worker is symptomatic, what's the appropriate set of procedures for returning to work? What needs to occur before that individual comes back? And maybe you can comment, because I think this also implies there may be different types of exposures.
Yes. So the issue of an ill healthcare worker is guidance that was in existence well before COVID, which is if you're ill, you shouldn't come to work. That guidance has been reissued and reinforced, and one change is we are more actively asking our employees to attest that they're well before they come to work as part of the badging process, and there's been communications that have gone out around that. Healthcare workers who are ill should not return to work until at least a day after they have recovered from that illness. In the setting of the consideration of COVID-19, that's something that, together with one's provider or with employee health, a decision can be made about whether that should be evaluated. And then there may be different guidance about when someone with either suspected or confirmed COVID-19 comes back to work. And that's guidance that has really very recently been issued. It might involve testing to see if there's presence of the virus. It might involve waiting a longer period of time after symptom resolution before that person comes back.
That's great, Ken. And we're working with that guidance and synthesizing it from the CDC. Again, we mentioned it's on the Atlas website. Now, I know some of you are probably thinking, what is the Atlas website? Because you're not on the HCA internet. That's okay. Ask the nurses or the management team, your chief medical officers, how do you get access to the information on that website, and they can print out the flow chart that describes the sorts of return to work algorithm. Absolutely terrific. Okay, so let's, for example, say, I'm going to build on this question that's asked here, that you're a clinician who's had a possible COVID exposure. What are the protections for the asymptomatic individual or the symptomatic individual in terms of their family and life at home?
Sure. So healthcare worker who is exposed to COVID-19, this is something that we're having to address. There is a risk assessment process, and that is, again, outlined by the CDC, where people can go into a low, a medium, or a high-risk categorization. And that would determine what they do in the workplace and what they do at home. The CDC guidance is that healthcare workers might return to the workplace with appropriate protections, such as wearing a mask, doing active symptom monitoring, and the CDC has endorsed that based on data that suggests to support the fact that that is safe for coworkers and for patients, that wearing of a mask as to protect one from spreading droplets if one was to be COVID infected. Now, obviously, if that healthcare worker develops symptoms, they would come out of the workplace. In terms of being at home, there is some recommendation in terms of social distancing, although it's acknowledged that one is in the family environment with others that have likely already been exposed. So there's some practicality there in terms of managing social distancing within the same household. And again, if that person is asymptomatic, then the chance that that person is spreading virus is probably minimized. If the person develops symptoms, then it's time to be evaluated, see if it's actually COVID-19, and then that would change the scenario in terms of the recommendations for other people that were exposed to that person. But this is where testing really makes a difference. We've seen lots of situations where there may have been an exposure, someone developed symptoms, they may be pretty confident that they have COVID-19, and then it turns out not to be COVID-19. We're still in the midst of an active flu season. There's lots of other viruses around, and so the challenge is not everything that we're seeing is COVID-19 right now.
Well, you mentioned testing, and I just want to assert this point once again, is that we're working with LabCorp and Quest, the major commercial reference labs, to prioritize in this order inpatients or patients sick enough to need inpatient care and healthcare workers so they can be returned to work. We see an onslaught of, frankly, worried well out in the community, and candidly, our conversation with some of these large organizations is that there's a disproportionate impact on their testing. And so this is an opportunity to reinforce that our priority for testing as an organization, as clinicians, and as a country has to be on those patients who are sick enough to be in the hospital and on the healthcare workforce in terms of returning to work. Okay, well, you mentioned the flu as well, and let's shift from healthcare worker exposure to actually the clinical course of patients. This is a complicated thing. It looks like it's so similar symptomatically, but there are cases of dual infections with influenza and COVID, and be interested in your perspective on kind of navigating that delineation.
It's possible. It appears to be rare. It's somewhere probably between 2 and 10% of cases of documented co-infection. So I think it's really a matter of clinical judgment. It has to do with having knowledge of what's circulating in the community in terms of the amount of flu versus the amount of COVID-19, and making a judgment based on the presentation. I think what we're going to be seeing in the near future is flu numbers going down. We're getting towards the end of flu season. Those numbers are already starting to decrease, and yet, as we well know, the COVID-19 numbers are coming up. And so I think there's going to be less diagnostic dilemma and less likelihood that we would see actual co-infection.
And you're advising against the broad viral testing panels. Maybe elaborate on that a bit.
Yeah, it's really, it's not often that is going to change management because, especially as the flu season is winding down, the chance that you are going to be using that viral panel to change management is going to be limited because most of the things you would be testing for are going to be supportive therapy. And so it really should be reserved for special situations where you know there's going to be some opportunity to change management based on those results.
And it also uses resources that might be better used, the collection kits and things,
Exactly.
the swabs, et cetera, which are also in somewhat of short supply. Okay, a question here came in that said, what is the role of chest CT? You mentioned ground glass patterns on chest X-ray, but is CT helpful in terms of confirming diagnosis?
Right. There definitely seems to be a characteristic appearance on chest CT, and there has been a fair amount written about that finding. So it's definitely a finding of interest, and it can be suggestive in looking at the overall picture of how a patient is presenting. It turns out that the current thinking is chest CT findings don't have a sensitivity or specificity high enough that it actually can be used to either rule in or rule out the diagnosis. So you will not see, at least today, at least within HCA, any algorithms that involve using chest CT for actually making a diagnosis. But there is a characteristic finding there, and that can be somewhat helpful in decision-making on care.
Well, thank you for those. Okay, the next couple of questions are actually permutations of the same, and it has to do with the risk of reinfection. The first question is immunity conferred by infection, and are there data on reinfection as well?
So like everything in this domain, the data is emerging. and people are trying to understand it. Based on other coronavirus type of illnesses, such as MERS and SARS, there is the expectation that infection leads to some level of immunity. It may not be complete. It may be a situation where it's relatively short term, and over a period of years, reinfection could be possible. It may be that immunity blunts a second infection but doesn't entirely avoid a second infection. But it's clearly the case that there is significant potential immune benefit in terms of creating a condition of herd immunity. As people are exposed to the virus, more people with immunity are in the community, and that will decrease the likelihood of ongoing spread.
Well, thanks. This next question has to do with the dynamic of the time. Obviously, we're incorporating the social distancing to flatten that curve for a couple of reasons. One, the hope that fewer people are affected, and two, that surge doesn't really overtax the capacity of the health system to respond. Some of the models, though, are fairly frightening. But on the assumption that social distancing in communities that are affected does, in fact, flatten that curve, the question is, what can we learn from other countries about the potential for a second wave?
Right, and it's another somewhat unknown, but I would say that there is a potential for a second wave based on the typical dynamic of a virus. If there is some seasonality to coronavirus, and I think it's believed that there, at least possible that there is, we may see a decrease in activity as we move into summer. That means that there is a significant portion of the population that still remains vulnerable, and as you move into next fall, there would be the potential for a second wave in the United States. Now, the possibilities are that we have a more effective therapy by then, we have a better understanding of the virus and how to protect ourselves and perform the best infection prevention techniques. Probably a little early for a vaccine by next fall, but there may certainly be interventions that would help us with that second wave.
Okay, and the last question is one that I think I'll take, and I think the question itself actually contains the seeds of the answer. In the face of this crisis, what else can be done to improve clinician resilience and support not just health but well-being? And that's a great question. In the past couple of years, there's been a lot of conversation about clinician and physician burnout. And the biggest barrier to well-being is work that's not meaningful. I can't think of a moment where our work as clinicians is more meaningful, where we're more connected to our personal mission, the mission of the organization, the care and improvement of human life. That said, there is every reason to have anxiety about the circumstances in the world, be they economic or the infection. The question is how we manage that stress and that anxiety and how we help to support our team members, in part by taking care of ourselves. For those of us old enough to remember the book, The House of God, I always remember the first rule. In the emergency, take your own pulse first. And if you're not focused, if you're not present, if you're not managing the anxiety effectively, then your team can't either. And it's been interesting. There have been a couple of really thoughtful publications on the importance of things like mini meditation in terms of just recalibrating. So during that 20 seconds when you're washing your hands, as we should be doing, and frankly, I don't think either Dr. Sands or I have ever seen hand hygiene better than at the moment, and we hope that's a durable effect after this thing abates. If during that 20 seconds we perhaps invoke the mini meditation that Deepak Chopra popularized, it's called Stopped, which literally means stop. So you can do the mechanical activity, but stop the thinking. T is 3 deep breaths where you're focused on the breath. And associated with that is smile. It'll settle you down. The O is observe your settings and think about what you need to do. And P is get back in the game and proceed. STOP. 20 seconds, a mini mental health break, one that I hope you can use, one that I hope your team can use. Let me be really clear. I'm not typically a touchy-feely person, but these sorts of moments really require us to bring our best game forward. And that's why Dr. Sands and I, Sam Hazen, our CEO, our leadership team, our physician and provider relations team are so incredibly grateful for all that you're doing to bring that best game forward and do what we train to do at this particular time. Thanks so very much. Please join me in thanking our Chief Epidemiologist, Chief of Infectious Disease, Dr. Ken Sands. And we look forward to being back in touch with you periodically with additional updates as events unfold. Thank you.